Person of dignitaries and participants to today's session. This is a part of the AICT Training and Learning Faculty Development Program on the broad theme of AI for Healthcare Excellence, Innovations, Challenges, and Future Trends. Today we are privileged to have with us Dr. Aniruddha Sinha. He is Distinguished Principal Scientist in TCS Research and an IEEE Senior Member. He has more than 27 years of experience in the area of signal processing, embedded system, and healthcare. He has done PhD from Jadavpur University in the area of cognitive analysis using physiological sensors and MTech in electrical and electronics communication engineering from IIT Kharagpur. At present, he is working in TCS Research in the area of biophysical computational modeling of the human organs, subsystems with a focus on personalization of therapy. He has published several papers in peer-reviewed international IEEE and ACM conferences and journals and granted patent in USA, Europe and India. Today he will be talking to us on revolution medical surgeries with the application of AI. Before the start of the lecture, let us take this opportunity to felicitate the distinguished speaker on behalf of our institution. I request you, Dr. Professor Jayantu Banerjee from HOD of Hospitality and Hotel Administration and Professor Suparna Datta, Vice Principal from Diploma Department, and also to join me Professor Dr. Dhruvasis Sarwar from Principal of SIMT, Coordinator Professor Dr. Mosumi Akbar from HOD of BMCT, and Coordinator Professor Dr. Uttara Basu from BMC Department.
Before Dr. Sinha starts his session, I am taking this opportunity to express our sincere thanks and gratitude to TCS as a whole, along with TCS Research, Dr. Sinha, Dr. Pal, and the entire team. Not only for past 1 or 2 years, since last decade when I am in the academic leadership, I am getting immense support from TCS for curriculum design, for student placement, student training, delivering module, and teaching us also like such kind of sessions. So on behalf of Supreme Knowledge Foundation, our sincere thanks and gratitude for accepting our invitation and delivering the session. Thank you.
Thank you, sir. Now, without further delay, may I invite Dr. Sinha to take the stage and start the lecture.
Yeah, thanks for the kind introduction and facilitation. Thanks everybody for this opportunity that you have provided me for the talk. Yeah, usually we don't give such presentations often because we are not from academic institutes. So I'll try my best to sort of fulfill the expectations that you may have, because it's a diverse field of areas that you belong to. So let's start with this. In between, if you have any questions or doubts, you can please communicate and we can have discussion. So this is the topic, and it's a large area because it's medical surgery and applications in AI. Right? So AI is a vast area and the surgery is. But we have tried to make a focus and a narrow scope so that to cover some of the use cases around this, and hopefully it will be helpful to in future to expand to other areas. Right? So this is the talk. This is the flow of the talk. Initially, there will be an introduction to the AI in medical surgery, and then we will delve into some of the use cases which we have been working on. And also some of the published work done by other researchers outside TCS Research. So it will cover initially some of the surgery-related video analysis, and why it is done, how it is done, why it is useful. Then we'll cover related to implant health monitoring. So because of joint dislocations or maybe degradation of the joints, there are implants that need to be put in knee joints or hip joints, and how the health is monitored for that and why it is important. Then the next, we'll try to go into a bit detail into cardiac related studies. It will involve some of the procedures, electrophysiological procedures that is usually done, and what are the challenges, and how it is handled, why this type of analysis AI and all that. It's more of assisting the cardiologist or the electrophysiologist. So we cover the atrial fibrillation use case. Ventricular fibrillation we will not go in detail, but a flavor of that depending on how it goes. And the use case related to congenital heart disease, which needs surgery for pediatric patients for correcting some of the defects that usually seen in the heart. Now we have started this area of the work recently. It is not yet matured, but to try to tell how the things will be utilized in that area and whatever foundational work we have been doing, how that will be useful. And then, of course, the challenges, ethical considerations, and future trends. Initial few slides are more of generic things, just to cover the basic stuff. Now, this artificial intelligence, as we understand, it's more to the machine to simulate some of the human functions, which will be done much faster because it will have consolidated information. So it's going to simulate cognition, decision making, right? So that's the overall human intelligence that is going to simulate. And this artificial intelligence is a huge domain. It includes obviously machine learning, deep learning, which is progressing now, Gen AI, using LLM. So that's the progression that is being done. And in the background, they use a huge amount of information that exists from the medical literature or any field, not only medical field, each of these fields. So they can actually consolidate information, and then it is trying to see the performance is becoming similar to medical experts. So that's where it is going. And in the surgery, the AI in the surgery is more to integrate multiple information. So it's like that particular individual's, how it is performing before the surgery or how the surgery planning is to be done, right, for the better outcome. So that is the place where the AI helps in the surgery. Now, the historical context in the AI in medicine is early AI systems were primarily focusing on diagnostic supports for healthcare professionals. Right? For example, everywhere the specialists may not be available. So, in the remote areas, rural areas, the ASHA workers or the military caregivers, or maybe general physicians who usually interact with those individuals, they may not be able to take decisions whether they need to be referred to specialists. So now the area that it is going to happen is there will be technologies which will support those individuals with maybe sensors sensing the physiology of the individual, maybe the ECG or some basic blood flow information like PPG and all. So from there, the technology is going to analyze and give reasoned output. So it's going to explain, okay, this is what the underlying pathology the machine is finding from the signals, and this is the reason why it is. So it's called explainable AI, and that will give more confidence in whoever is referring to the specialist. So that will hopefully reduce the burden that exists today on the specialist. So there it is heading, it's more of diagnostic support. Now, yeah, obviously in the technology evaluation, there are a lot of AI applications in medicines have been evolved and it is becoming more sophisticated. So new medicines are getting discovered, molecular combinations are being done. So there a lot of AI is being used in medicine. And in surgical innovations, it's related to multiple domains. One is the device. The device that is used for surgery, the implants, or the cardiac, the catheters being used. So they are progressing well, and the surgical devices mainly. So that's an area, but the more the complex these devices are, there are certain parameters which need to be controlled or tuned. They are becoming more, right? Maybe, for example, the intensity of a voltage that needs to be applied. Right? What is the duration of the voltage that needs to be applied once a catheter is inserted for some ablation procedure, which will go in detail. Now, those are simulated before the actual surgery is done, and the information is given to the electrophysiologist as a planning phase. So that's a improvement. And some of the basic principles of AI in surgery is the data analysis, which I told. It's a vast amount of medical information that exists, and it involves pattern recognition and surgical procedures and improving outcomes. And it is important to also look for safety along with the outcomes. And another big thing is the predictive modeling. So what happens if, okay, so before the surgery is actually performed, during the planning phase, one can do simulations that if the surgery is done this way, then the outcome of the post-surgery functional behavior would be like this. So that's important, and we'll try to see one of them, how it is. And in fact, after a surgery is done, there is a rehabilitation phase. So that the patient recovers over few months, and initial time is very crucial. So that time there may be relapse, recurrence of the disease, or maybe fatal scenarios. So during that time, the simulations would actually help in planning for an individual rehabilitation process. So that's the area which is called the predictive modeling. Now, how innovations in AI-driven surgical techniques are being used, like, yeah, of course, robot-assisted surgeries. Now, robot-assisted surgery is a huge field, and it obviously involves, it improves the precision of that individual by reducing an error, and it is minimally invasive, less trauma, of course, and it improves the faster recovery. Now, this robot-assisted surgery involves multiple disciplines. It involves the hardware, robotic feedback, haptic feedback to the surgeon and all. But this area today I'm not covering, robot-assisted surgery. I'm covering more on the functional aspects during planning. So AI in the pre-operative planning is helping for tailored surgical strategies, which is personal is using digital twins. Now this is important because a digital twin is a functional and structural simulation of maybe a component or a system. Now in case of human, it it could involve subsystems, it could involve organs, it could go to maybe molecular level. Okay. So there's a multiple levels of digital twin one can realize. So we'll cover a bit of that with the cardiac aspect. And once we do this simulation, it's a global model one can design. And then observing an individual's medical data, the model could be personalized. So it will sort of mimic that particular individual's functional condition, structural and functional condition. After that, in that simulation of the digital twin environment, one can do what-if analysis. By studying if this is done, what happens, or post-surgery, if an individual is doing this, what it will happen. So that way, the digital twin is really helpful. And it, of course, minimizes the risk and it reduces the post-surgery complication. So this planning is very important. Now in the peri-operative scenario, yeah, this is another important thing. It is basically during operation. What happens? The AI could actually help the surgeon in real time, okay, by integrating multiple modalities and also considering the pre-surgery clinical information. So this is another area which operative condition I am not going to cover. I'm going to cover mostly the pre-operative and post-operative. In post-operative condition, the rehabilitation plan, as I told, it's a predictive modeling using digital twins, which is focused, and it also helps monitoring in the daily living conditions. So once a individual is outside the hospital, of course, after surgery, some intervention, in the daily living condition, how the symptoms are changing, right? So they are not monitored well today. And that's the reason what happens, there is a sudden relapse or maybe adverse events could happen. Right? So that's an area which being focused now very thoroughly. So that reduction of readmission is achieved, right? And mortality is reduced. Now, in the AI-enhanced imaging and diagnosis, so this is another very important area where the imaging technologies, modern technologies like MRI or CT, it enhances the diagnostics accuracy and advanced AI integration. Now, why this is important is the diagnostics, if it is not done accurately, then selecting an individual for operation or procedure becomes incorrect, right? Which is not good. So, yeah, this one area is important. So, patient selection and a patient who will respond or not respond. This is also critical. So, many a times, depending on the symptoms, doctors, of course, today they have medical guidelines. They decide to select an individual for surgery, but certain surgery which are a bit complicated, especially brain surgeries, it is very difficult to know whether an individual will respond to certain procedures. Now, in such scenario, what-if analysis using digital twin of that individual helps. And there the imaging technologies are very useful. And it could also give clearer insights into the patient's condition to the surgeon. And AI in image and recognition, of course, it involves advanced imaging technologies and abnormalities. And it, of course, assist surgeons for planning and critical decision. And integration of the diagnostics in the surgical. Now, this is another important area. It's a comprehensive patient data, and the surgical teams have access to. The comprehensive patient data is actually used. So, all the metadata, the clinical records, past history, integrating all this together to come up with a decision with explanation is going to be the future. Now, doctors do that today in their practice. They form a team and do, but there is a lot of variability in that. So, you go to one place, you see the response one way. You go to another place. However, this AI in future, is expected to reduce that variability in the treatment. So that's a very important thing. And in all this regard, the work, the research that we do, you will find a lot of open source data available. The longitudinal data is very rarely available. However, there are instances of imaging data, physiological data, and some of the medical records which are utilized for developing the algorithms of the computational models. Right. So now, before I go into some of the, so this was basic introduction about what we can in general think about how the surgery and the AI relates, right? This sort of covers the spectrum. Now, before I go into some use cases, I'd like to just have the acknowledgement done in the beginning itself. So, the work that we're going to present, discuss today, it involves work done by a larger team in TCS Research and Innovation. There's researchers and scientists. I've listed some of them. There are many more beyond this. We have domain consultants in TCS as subject matter experts. We have a cardiologist, Dr. Sandeep Khandelwal. We have orthopedic surgeon, Dr. Murali Koduwal, with whom we closely work with to get domain information for the research. We have clinical collaborations with multiple hospitals, and we have academic collaboration. So, some of the work that you are going to see is done by all of us together. So, let's start with some of the surgical video analysis related work. So, these are the 4 areas which we have touched upon in our lab, and there are many more beyond this. But if we cover some of these, you will get an idea about how things go in this one. The first one is related to surgical, laparoscopic surgery, where the surgical smoke detection. So what happens in a laparoscopic surgery, the tissue where there is damage or something, usually there is a lesion done, so that the aberrant tissue or the tissue which is functionally incorrect, so not functioning as desired, they need to be damaged, right, purposefully. Now, in that process, what happens? So, the laparoscope catheter, it has a camera, and of course, it has a electrode for doing the procedure, the scar formation, the lesion. So, that the camera that enters, that view the surgeon looks. So whatever the camera captures in that channel of the laparoscopic part, the surgeon will see. Now during the ablation process or the damaging the tissue, which is bad tissue, there is the smoke that comes out because it's burned, and due to the smoke, the camera view gets blurred, and till the smoke is naturally taken out through a process, the surgeon doesn't have a clear view. The challenge is that can this image processing technology be used to improve the vision obtained from the camera such that it could improve the speed of the procedure rather than they have to have a delay every time, right? While acting. So that's the motivation of the first one. And so one is smoke detection, and then the second one is removal. So basically, through image processing, can the smoke be removed and a clearer vision can be given? Right? So that's the challenge. The third is related to surgical tool detection. So during a surgery, multiple tools are used. Okay, and it is important to have a algorithm which will detect these tools from the video of a surgery. Now, the use cases, okay, so we have say 30 minutes or 1 hour of actual procedure done, the surgery is done, and post surgery, we need to analyze how the tools were performed, because the device companies make these tools, and they need to be aware of how the surgeon is actually using this, whether they are using this properly or not. They also need to understand whether these tools are performing well. Okay. So, and also this surgery videos are used for training purpose for the new surgeon who are trainees. They are also being used. Now, the video analysis software that is required to be done from this is, can it segment regions of the video which a particular tool was being used, or a set of tools use their interaction. So that's the area of research which is important. And fourth one is related to bleeding spot detection. So it's again using laparoscopic video data. When so there's a surgery done, and where are the bleedings coming from inside? So can the image processing algorithm automatically detect those and assist the surgeon? So these are some of the areas in which we have been working on. And so what happens? The use of carbon dioxide gases to inflate the body cavities and energy instruments for dissecting the tissue leads to generation of variable amount of smoke. So that's what I told. So tissues get dissected and smoke comes up and it degrades. Now it sort of reduces the visibility, it increases the surgical risk and increases surgical time. Now let me play a video and then I come back there. Yeah, so here you see the smoke is coming out on this left side. And yeah, so here, let me pause. So here is this is the original one. There is a smoky image where the smoke is coming, and then this is a reconstructed one. Okay, and so here there are two more are covered, but okay. Let me go back to the. Yeah. So, so in case the challenges are like the smoke that comes out is non-uniform and it varies in concentration. The transparency is varying. Like the light source. Okay, so it has a camera and it also has a light source. Depending on the light source, the reflection that happens is challenging for the image processing algorithm. Right, information is uneven. Now, the detection aims to detect the presence of the smoke and using machine vision algorithms, it sort of detects, and some deep learning algorithm is used to do the detection and then do enhancements as if the smoke is sort of reduced. Now, in that enhancement process, it might change the texture and the color of the actual tissue, which is incorrect. So, it should not degrade the true texture and the color of the tissue. So, that is. So it's important to know the region where the smoke is coming from and then do enhancements. Yeah, so exhibition is something which is an internal term in TCS, which is
it designed by
yeah
TCS for this interfacing?
Correct.
API made by.
Yeah, so it involves API and the algorithms also.
So it's not it's your algorithm, it's not a public one.
Okay, so this work is published, and I think yeah. So this particular slide, it has the reference. So we'll give that reference along with this, and it details about. So the data set that is used is from open source, so you can access the data, and it also gives the analysis algorithm, vision-based algorithm that is being used. It's a deep learning algorithm, so we sort of maybe design the architecture slightly differently and tune the hyperparameters to get the performance. Here, the unit was used for identifying the smoky frame, so every frame don't have, so continuous the video. The segment of the video was initially done where the smoke comes out. And the reference frame which was actually clean before the smoke coming out, because smoke comes out once the tissue is burned. So before that you know how it is. So using these two and of course the light glare interaction, so that sort of procedures. And the color normalization has to be done. So once the smoke is removed, the color need to be restored and how well it performs and all. So that's the overall approach. This particular publication has that.
One more question. You another term you have written unit.
Yeah.
Is
So,
it again a architecture designed by you?
yeah. So unit is one of the standard architecture. So there's an encoder path, a decoder path, and the variation of the unit is done like this. So we sort of get a standard architecture of unit, publicly available.
On what basis? What are the challenges you face to, work and on basis of what you have customized?
Yeah, so what happens when we use those images to train the unit? The training is done for detection, right? Which segment the smoke comes. Second training is, second is after the detection, the enhancement to be done. Now the detection zone, whether it's correctly detecting or not, depends on the data set. Right? Of course, depending on the question. Now units, you get pre-trained units which are trained on standard images, not for laparoscopic surgery. So people sometimes start from pre-trained network and then modify based on this particular domain. Okay. So those modifications are usually, basically the weights are defined based on the data set.
Your algorithm exhibition, is it using exception model? That's why it's name or something?
No, it's not exception model. Yeah, no. That's something term you have given. Enhanced vision.
So this paper has that details.
This
Did
publication has
you
the
try YOLO model or just
Yeah, yellow been tried recently. This slightly older. Yeah, actually, see, if you have a data, say image, video data, you could use multiple networks. Yeah, now CNNs are also used. Right? So, and yellow is a package where multiple architectures are there. Now, those you need to use and learn, but when you use and test, the thought process should be that why I should choose a particular network. Right? So that comes with experience. But here it's a guideline on how it is done, what are the different areas in which one can work on. Right? This is another use case which is bleeding spot detection. Now here also, see the dataset will have these input images. These input images the dataset will have, and this is the ground truth. Some of you are not sure whether it's seen this. Now this binary map sort of gives where the bleeding is there as a ground truth. And using these two information, the machine learning or the network is trained. And then once the unknown or the test input is given, the prediction is done. Right? So depending on the difference, one can see how these accuracy. Now I haven't got any specific slide on how the accuracy is derived, but this is something which is important. Some of you may know, some may not. But this dice score is going to sort of see how the ground truth pattern is and what is the predicted. Now some of these will overlap, some will have non-overlapping regions. Now if it is perfectly overlapping, then dice score is 1. It's basically intersection and union of the two. So the predicted area should be perfectly matching with the ground truth. right? That's the expectation. If they don't match, then that's the error in detection. Now that is usually computed using a chi-score metric, which is standard one. And here we used deep learning method, and this is the publication that is given. So you can look into this.
So there is a variation of patches, right? So somewhere the colors are different. So
Yeah, so that's a, so for example, this is the image, and the ground truth, whoever has generated this.
the left one, you can see the reddish patch. There is a dark red on top.
Right.
Right.
So yeah, there is the darkest region, and this is also red.
But it is both the cases. It is almost generalized. Means
Correct.
Few are not correct. Means I don't know is correct. That's clinical data. So the patches somewhat it is not being.
Yeah, this region, right? So
Yeah.
this region, it comes somewhere here
Yeah.
separately, right? And this usually this ground truth generation is done by the specialist and not by one person. It is done by multiple people, and their agreed thing is taken. So here we need to assume that it is correct, but somebody has generated. The algorithm or the machine learning algorithm should be able to predict whatever is given here, right? So that's the way it works.
Sir, I have something to say. Sir, maybe that is not a dark red patch, that is the pathway to a different lobe or to a different, I think so.
Yeah, but there is a deviation, right?
But that is the opening to another lobe, maybe.
Another.
Right.
So it is not big, it is
It's not a
generalized.
bleed or something, but it can be a pathway to another lobe or to another part of that.
But not separately depicted in.
Yeah, so that was not the purpose for this work. Yeah, exactly. So there is no separate annotation for this. Actually, the bleeding source is here. From here, the bleed happens. So that's also included. Right? The source is also included as part of this. But this algorithm is not going to tell what is the source. It's going to detect only the region. And actually, this one is supposed to be used during surgery. Okay. Though this algorithm is developed offline and the accuracy is tested, but actually when the surgery is happening, the algorithm is supposed to assist the surgeon, and the surgeon can do a verification with the algorithm. Okay, this is the region. So it's a candidate for real-time usage. We haven't gone there.
One more question. So your paper wrote about precise bleeding. So is there any specific?
Yeah. So precise bleeding and revolution, right? Yeah. Sometimes we give these names to indicate that it's an enhancement compared to the previous work. So we give some adjective precise bleeding region detection. Okay, so next one is on the surgical video analysis from cholecystectomy. So it's a colon region. So it's a laparoscopic surgical procedure which removes the organ and the pear-shaped organ below the liver and upper right side of the abdomen. Now, so this particular work had video data for this procedure, and it included multiple surgical devices. Multiple surgical devices were used. So here the challenge was multiple tools were there at the same time. So when this surgery is happening, many a times two tools are used. So if the question is, can you extract or segment the videos where a particular tool was used, and if there are two tools simultaneously used, then it becomes more difficult. So that was one challenge we faced. Then the camera view can be blocked by smoke of the burning tissue. So then it becomes more challenging. So they are related. So smoke detection and surgical device detection. Then there's a multi-level video object segmentation. So it's called instance segmentation. It's more complex, and multi-level means multiple tools are there. So multiple labels are there. And compared to cataract surgery or robot assisted surgery where the camera is stationary, here the camera also moves. Okay? So that's a challenge in laparoscopic surgery. The camera actually moves with the catheter and various size and location. So these are the challenges we have seen. In this particular work, these were different instruments, right? Grasper, bipolar, rope, like that. And these images are shown just to demonstrate those images, but it's actually a video, right? So each image is processed separately. So for example, here this is the input image, and this is the ground truth, where the surgical tool is present. And this is another label ground truth where the second tool is there, this is the third tool. So in this case, there are three of them. And though it is shown in a binary pattern, it's more for detection, presence and absence. After that, the identification is the next level. Okay, so it's a two-stage. One is region detection, where the tool is, and then what is the tool. So, and this particular algorithm was tested on two network architectures, UNIT and MASK RCNN. And this is the performance. Now, the architecture details are given in the paper, but yes, we could achieve some amount of accuracy and mean accuracy. There. And yeah, this results are in the paper where multiple authors. So there have been many work on this. They have also done this. And this data set is open. So we covered a portion of using laparoscopic surgery video processing. And next maybe 15 minutes we'll cover this and then we go to the cardiac. Now this is related to the implant health detection. This particular image is interesting. So what happens on the X-ray plate of the image, you see this annotation is done. Okay, so this is done manually to sort of label where the implant is, what are the shape and all, what are the dimensions. So that's actually done by the surgeon for future education purpose or creating ground truths, right, for the machine to understand for the segmentation of the implants. So this is an overview about what is orthopedic implant. Most of you are aware of it. That many a times if there is a fracture or there is a degeneration of joints, some device had to be put, which is called implant. And obviously it is biocompatible, which assists to recover the function of that joint. So that's the orthopedic implant. Now usually this is sort of planned using CT MRI of that particular joint or bone, but it takes the alignment information and all. But the challenge that we haven't covered in this talk is the dynamic nature is not covered. Like for example, when we actually walk, the knee joint has a dynamics. Now in the presence of implant, how it will be is sort of not analyzed that well. In the static, it is analyzed today. Hence, many a time, some of them respond well, some of them don't respond well. Okay, so there are two things. One is static, dynamic. The gait, when the gait is actually happening or the movement is happening, the joint load or muscle forces are today in practice, medical practice, it is not used to sort of choose the implant or do the process. That's in the research phase, which I haven't covered today. You can get open source data also, where the sensors are actually embedded in the implant, and the data is captured for those patients post surgery to understand how they are actually performing. The implants actually is helping to reduce the force in the joint. So that we will get some good data set also. And this I covered what we need and what is the reason of the failure. So another challenge is See, after this implant is done, after a few years, some of them might become loosened, and orthopedic surgeons see that. So from the X-ray, can it be verified that there is a loosening happening? Okay, so that's another area which we have worked on, the loosening of joints. So all this related to implant health monitoring. So health of the implant is monitored. So there are two things. One is implant selection, planning phase, which we haven't focused here. But once the implant is done, whether it is, first of all, first thing is whether this implant is done from the device company which it was meant for. So before the surgery, surgeon will tell, okay, I'm going to use this company's implant. Whether it's actually put or not, that is done post-surgery, X-ray is done. Now from post-surgery X-ray, many a times it is not clearly understood. Now this is more from insurance perspective, whether it's properly done or not. Other reason we may need it after a few years, once the patient is uncomfortable and they need replacements or need to understand what is happening, that time how do you know what company's implant was put? Patients may not remember, they may not have papers and all. So that time the images are used to find out what company's implant. There are 5-6 companies only, 4-5 companies. So depending on the type, through image processing we can detect. So there is another challenge. Many a times these implants are not successfully put. So we have revision surgeries done. So because of infection or dislocation of the implants might happen, or there is a loosening, right? Loosening of the breakage. Now this is a big problem. Now can the X-ray be utilized to sort of quantify this? How much dislocation, how much loosening and all. So it will help the orthopedic surgeon to actually quantify it. Now again here it comes, there are few surgeons who have not many experience and they can do actually maybe better than the machines. But there is a variability in the skill set which the AI can reduce. So they can make all of them equally skilled or close to equal, right, with these assistants. Yeah, so it involves automation of the manual process, automation of detection. Now, this is a pipeline which we have. So, this is the detection suite, and each of this block involves algorithms. And so, initially, the X-ray image is sort of validated whether it is fit for, check if it is fit for diagnosis and all. So, yeah, so then the implant detection is done. So, how it is done? This, as I told, these are X-rays. Post implant, and this the annotation is done. Now same way this ground truth, the binary map is generated, okay? And the machine learning is trained with the ground truth and the images. And then this implant detection phase works. And the implant of bone localization and the manufacturing detection. So depending on the shape and all, the manufacturer also could be identified because there is slight difference in the shape. Machine can learn given the instances they see. Okay. And obviously the implant size detection, whether there is any defect and all, whether there is any bones implant extraction. And, yeah, then there is a classification and loosening. So here also it is important whether there is a loosening also. Okay. So the implants which actually got loosened and confirmed by the orthopedic surgeon are taken here as the image for training and testing, and then there is a data set available in public domain for that. But some of these data were not, the annotations may not be fully available. You can look for the paper, publication is listed here. We have done these annotations manually, and we are not able to open a data set because of some reasons. But that's one, if you work in this area, you may get some hurdles in that space. But this is a very challenging thing, and Dr. Dr. Murali, who is the orthopedic surgeon, told that this is something which is very important. Okay, implant health monitoring, which is very difficult for today to understand whether an individual needs the surgery to be done again or not, okay, or he can survive for 10 more years. So that's very fuzzy. So the impact what you see is that obviously the pre-planning, then the screening post for implants, patient dedicated health report, early detection of the failure from X-ray images itself, and then it could overall enhance the diagnostics and the surgical procedure of the. So these publications can be referred to for data sets and possible. So here it comes to the first two topics. Now we'll slowly enter into the cardiac procedure, and yeah, some of you may not be aware of some functions details, so I go slowly in case any questions you can ask. And some of you may be more expert than me, you could correct me or assist in how it goes. So some basic anatomy we'll just tell. There's nothing in detail. This is the cross section of the heart longitudinally. There are 4 chambers. This is called left ventricle. This is right ventricle. It's cross sectionally cut. So left ventricle, right ventricle, left atrium, right atrium. Right? So these are the major 4 chambers. And from left atrium, the blood comes from the pulmonary circulation. It enters the blood flow. I'll show later. And then the arteries are veins. So if you remember 4 arteries, that is good enough. Many of us read in biology. So let's go ahead. Now this is the electrophysiological component. So heart has a special muscle which contracts and expands because we have the heartbeat. Right? And this contraction expansion happens because of ionic exchanges. Now these are some of the details which we may not need to worry on. That's not important. But what is important is to understand this function, because we may program this thing or analyze this. This involves an excitation phase, which is depolarization. Depolarization means there is an ion exchange happens between the cell and the outside. And at this point, because of sodium influx, this happens, and there is a plateau and there is a repolarization. So again, it comes back to the initial state. Now, this particular excitation and relaxation is a property of the cardiac muscle, which helps in keep the heart beating. Okay, and because of this electrical changes leads to increase in the force in the muscle, which contracts and relaxes, and then in turn pushes the blood. Now, what is important is there is a particular flow of this electrical signal happens through the cardiac surface, and this signature is not same for the full structure. Okay. This is the point which is called sinoatrial node, which the name is not important, but there is a point from where the electrical pulse starts, and then it propagates in a particular trajectory. Okay, it goes to this atrial muscle, then arterial node, and then it branches into 2 parts, left and right ventricle, and then finally some name is there, Purkinje. So this is the function. This is the electrical function if observed at this point. The depolarization and repolarization. The signature is different for different region. Now this is important. And when we observe on the body surface, the ECG, it will look something like this. Right? It will have a specific 1 wave per T wave, which will some particular wave. Then there is sharp change. This is called QRS and this P. So these 3 terms, if you remember for now, it is good. So what need to be known is this duration that is there, and this image is taken from this book. This duration and the timing there is a rhythm that is maintained. Okay. Now, whenever there is a disruption, then it leads to arrhythmia. And if this conduction pathway, there is a specific timing that it goes, right? Relay and all. So that is important. And because of arrhythmia, the heart is not able to actually pump the blood the way it is required to, and hence we feel uncomfortable and all, and then the procedure needs to be done. So this relates to the electrophysiology. And this is the hemodynamics, the blood flow, how it happens. Now, this ECG that you see on the body surface, it has multiple phases, but what is important to know is from this atrium to ventricle, the blood enters during a particular phase. Okay. At this point, this atrium actually contracts, which is depolarization. And then blood enters in the left ventricle, and later the blood then goes out, this oxygenated blood, goes out and gets circulated in the body. And the deoxygenated blood comes from the right ventricle. Now, the amount of blood that goes out against it came in, there is a ratio which tells what is the efficiency of the heart. It's like efficiency of engine, we can relate. So what is to remember here? There is a blood flow that happens, oxygenated blood flow from a particular chamber to a ventricle, and then when this contracts, this blood flows out. Now this is the blood flow concept, and it is driven by pressure volume changes. So in basic physics, when you have studied, it follows the same principle. Okay. Now the thing is, using these concepts, we have developed a cardiac computation model which is still getting enhanced, which uses multiple information. So we saw this electrophysiology, we saw this hemodynamics, and these are functionally implemented to replicate the way it should be, right? There is a biomechanics component which we are still developing. Biomechanics means if the electrophysiology changes this much, there is the amount of force that is given on the structure, right, which helps the blood to flow. And there is a pulmonary component which is linked to this, which is important. Yes. Oxygen exchange happens, and then that gets circulated. Now, what you see above is the input data, the clinical image data, or the ECG echo. Now, these two are recorded in the clinic. Outside the clinic, we can actually get some information from the wearable when he is outside. Now, that wearable data could be the EPG, the blood flow. It sort of gives us this called the as per timing and sort of an intensity. So the concept is, if we develop initially a global model which sort of replicates the blood flow concept and the electrophysiology, and then personalize that model. When I say personalize that model means, when we see the echo report, doctor understands, okay, how to some extent, what is the end systolic or end diastolic volumes, or what is the flow rate, what is the valve condition. Now those parameters we actually use to tune this global model to make it personalized for that individual in the initial stage. Now once that is done, that is called personalized model. And later this model is used in the real life scenario to extract echo type of information from the wearable, because echo you do in clinic, but outside how it is, you have no idea. Right? But doctors also don't have the data today. So in TMT, when you do TMT, you get a running state ECG, you could get blood pressure. But the ECG is then could be used by this computation model to extract echo information that I have to cover here. And these are various use cases, out of which we'll try to cover this AF ablation thing. And we'll see how it is. Now, I'll just pause here. You could tell me in case it is getting to a state where it is not at all clear, then I'll try to change things. But if you are able to follow it is good, but if you have any questions, you could please ask now, because we need to go in a track. Yeah, any reaction or feedback how it is? Yeah, if some things are not clear, you can actually tell now.
For the hip implant, this usually may occur in several reasons. Smart maybe infection, maybe bone cement rejection, or trace imbalance, etc. These type of data, as well as the implant materials itself. So these data you are getting from the physicians.
Yes.
And as well as it is due to the customized the implant also. If it's a general implant, they may fit not suitably fit for different type of patient. So all these data taken and feed into the AI model for getting the pre-information regarding the failure.
Yeah, so what happens, so assume that there is a database of what you just told, of previous patients, right?
Because there are so many variations.
Yeah, so many variations are there, right? So, yeah, so given an X-ray, doctor can actually tell whether the implant is loosened or not, right? But they may not be able to know what is the reason for loosening. That may be different. Whether it is infection, whether it is damage in the implant. Sometimes they may tell, be able to, sometimes may not be. But whether there is a loosening and whether it needs a reset jelly, that type of assistance could be done by machine learning, provided it has past data of years of multiple patients, right, where you have seen variations of such things. Then the machine will learn, and in future, given the new patient's data, it can then predict. Right. So that's the way it is, and the data set that is used in this publication, the previous one, had such data.
And you also mentioned the sensor placed in the implant.
Yeah, so that is
and
so,
sensor where is placed? In
Yeah,
the
right.
skin or in the ball? In the cup.
So this particular thing is a research that is being done by a few centers for future enhancements of implants, where there are special implants designed for certain recruited patients who are actually taken for the study. So they are of the order of 5 or 10 worldwide. The sensor, the load sensor is placed on the implant, and inside the body it goes, and it stays for years.
Skin, within the skin.
Yeah, within the implant itself, it is attached. Yes, and then it senses the force, right, in the joint. That data it gives in real time, which is not there in regular implants.
That is taken in the real time clinical patient.
Yeah, so that is
information to the sensor.
exactly. So that is done for the study, special study to improve algorithms. Because in the real scenario, what it will be done? A person who is actually walking around with the implant, seeing the angle of the knee joint or the hip joint, one can estimate the joint load and muscle forces. That's called biomechanical modeling. Now this biomechanical model has lot of assumptions and some parameters which are tuned using that observed implanted sensor data. Right? So that's a research done.
But there could be a shadowing because of body movement, there could be signal distortion also.
Yeah, so camera from camera if you want to detect the knee joint or the hip joint angle, that's what you are referring to, right? What is the shadow you are talking about?
Because if it's an implanted sensor and there is a body movement, because if it is implanted there, it cannot restrict the body movement.
No, it will not restrict. That's the way it is designed. So patient will not know or feel anything. That's a special one. That's not done regular work.
Is allowed to.
Sir, can I?
No, that is done on people who are recruited for specific research and study. very few for that purpose only. Device companies do that. Yeah, sorry, I couldn't get it.
No, I just there is a study of GAIT, gate analysis. So these companies, what they do on the basis of feedback, they provide a customized implementation mechanism, right?
Yeah, they try to do that.
Because so for example, that's a foreign element in my body. So my body may react in a different way, like it is already done with other patients, right? So there are some pattern, I think, there to understand the how means there is a simulator which
Exactly.
can tell that how the body can react before implantation. Like your paper also showing that automated shoulder implant. But there is a study, right? Before I go for some knee surgery with some foreign equipment or something.
Yeah, usually, in clinical practice they don't do today. It is in research phase.
Okay.
For future improvements, where you are right, before the actual operation, they should study the gait and then understand whether how to place the implant. Today, using X-ray and MRI, the
That's a normal process.
static is done. But what would happen, how the gait would be, and when the walking is happening, how the joint load muscle forces are post-implant is still in research phase and the publications are done. So that in future it will become a guideline.
Yeah, because you are showing something which is post surgery syndromes, like it is loosely behavioral pattern because of the patient. It's a patient behavior, how the foreign body it is reacted in the orthopedic surgeons are telling. So based on the data, do you have any research which is there in the real life practices to improve this model?
Yeah, real life it is not used in the practice today. Yes, so it is still in research.
Nothing done implemented.
These things takes time. Any questions on after that? Or anybody, any other questions? This cardiac thing, you have any questions before I proceed?
I have a question. It's not a question, I am just asking about my experience. I have a foreign body myself. It's a titanium plate I have. And when the operation happened, the doctors told me that it is better to use titanium plate than the steel plates. Why can you clarify these things?
Yeah, I don't know why the doctor told I'm not a orthopedic person. But of course there are things.
Something reactions are.
So it has
the reaction is.
it has to do with the property of the metal. One is obviously the weight strength and all, and then the biocompatibility. So these device companies come up with new materials which are more biocompatible and it will stay for long duration. So those are the reasons new products come out and they have those features. Right? Of course the cost will be more. So it depends on the individual age also.
It also depends on the
Please give
location.
me a catalog if location is
If
this.
it is deep implant, then stainless steel 360 but it is a plate, well, lightweight, that's why it is stainless steel, it is more biocompatible and as well as cost is high.
Yeah,
It's
exactly.
very high.
So depending on the condition.
Yeah, those things are there. Many reasons are there.
Negative difference in titanium is higher than steel. The chance of reaction is.
Okay, so let us proceed with this. So we saw the electrical signal in the cardiac, how it gets generated, how it flows. And there is a rhythm that is there, rhythm in terms of shape and timing. If the shape and time changes, then there is an arrhythmia. What is arrhythmia? Is the way the contraction and relaxation are supposed to happen between the four chambers. They don't happen, and the blood doesn't go well. Now, one such arrhythmia is called atrial fibrillation. Okay, so it's quite common actually. Atrial fibrillation is a phenomena where the atrium chamber portion of muscles are fibrillated. Fibrillated means they don't work in a normal way. the electrical properties change, right? And because of that, the path in which the voltage traverses or the potential traverses, they get disrupted. And the timing between the atrium and the ventricle, there is a timing because one atrium need to contract, the blood need to go to ventricle. Ventricle need to expand. So there is a synchronization that is there. That gets broken. And that's the effect of reduction in efficiency and all. Now that's called atrial fibrillation. Now how that gets manifested in ECG, doctors know how to read it. Okay. There is a specific signature in the ECG. Two primary things. One is the P wave is not well visible, and the R, this P wave, this R wave intervals vary randomly. This is the sort of known thing, and these are four different stages of a patient could be. It could be just an initial phase, sporadic, such events happening, not always, seen for a few days and then becomes normal. It is staying for more than 7 months, then becomes persistent, more than 12 months and all. So there is so initial stages for the medications happening. Now, so if it is seen these episodes, that patients, this ECG, when there is ECG is taken, it may not be seen. Right? Maybe in the evening he is feeling uncomfortable, if the ECG is seen that time, these episodes can be seen. So it is important that from two reasons. One is this so after few months of medication, if the improvement is not happening, then there is a procedure that has to be done. And that procedure is invasive. A catheter is inserted and that tissue is damaged. I'll briefly tell how it is done. But in order to plan for that, they need to know how often this episode happens. Right? This is called AF episode. How often it happens in a day. Right? So that's called AF burden for that individual. Now depending on that, they have to take a decision whether should I do this procedure or not. So, so that I just told in the pre-surgery, there is a planning phase where there is a detection to be done, and after the detection, they need to know where is the source. Okay, because atrium is quite a region. In that region, maybe 1 or 2 points, the tissue is damaged. So, can it be known where it is? So that only that portion can be, scar can be done, or the tissue could be deactivated so that it doesn't generate erroneous electrical signals. Okay, so that's a concept. So in the pre-surgery planning, this is important to be done, and we have done some work, and you can also look into. During surgery, there are tools and softwares available to assist electrophysiology, which we don't intervene now. In future we could. And there is a post-surgery prediction. So what happens after the surgery is done? The electrophysiologist says that I've done it. Now he goes back, he or she goes back in daily living conditions. Sometimes they feel uncomfortable, may not feel uncomfortable. Now, in that scenario, the digital twin actually could assist for generating early alerts so that the recurrence of this AF doesn't happen. Okay, so when you have a scenario for any procedure, this is atrial fibrillation scenario, any surgical procedure will have these 3 stages, right? Pre, during, and post surgery.
Sir, for atrial fibrillation, you certainly see only atrial defibrillator.
Yeah, so no. So the defibrillation is done through a catheter that is inserted into the atrium through vein. Okay, and the tissue where the fibrillation is done is seen is damaged. So that's called defibrillation. It's an invasive procedure. RF ablation. It's called RF ablation. And yeah, cryo is there. Yeah, yeah, it's actually invasive procedure. It's similar to laparoscopy, you can think of. But the challenge is, from the electrophysiologist, it is known that the complexity of the arrhythmia is usually not known upfront. And for ventricle also it is similar. So I haven't got separate slides for ventricles, I'm telling you. So ventricle, sometimes a scar formation is done or because of ischemia. Such arrhythmias can happen. So where exactly it is and what is the intensity of it is not well understood unless MRI is done many times for ventricle problems. So can it be non-invasively from surface ECG? We can estimate the amount of fibrillation, what is the location of the fibrillation, so that the electrophysiologist can take the catheter in that region and can speed up the surgery. Okay, so we have discussed with Dr. Azizul Haq and he sits in multiple places. He's a well-known electrophysiologist in Kolkata. He told, we saw that, in fact, after a few hours of attempt, many times electrophysiologists are not able to successfully correct the atrial fibrillation. Many times they do in pulmonary vein junction. So that's one challenge we have, and for that, okay, so before we go for that particular area, what I want to say is, if you remember sometime back I told about the burden of atrial fibrillation. Burden means what is the intensity of the episodes. How many times the RR interval is irregular, how many times the P wave is not seen. Can we detect that from a single lead ECG, which is owned outside the clinic, maybe 24 hours? It's like a halter. Right? It's a low cost halter type of solution. And for the single lead ECG through signal processing, we detect the atrial fibrillation episodes in an embedded device. Right? So this is the work that is presented using some AI-based algorithms where this ECG signal is fed and the CNN sort of detects the presence and absence of E waves or RR intervals and then quantifies the air burden. Right? And this particular publication you can see it has some details about the algorithms, how it is done. Now this is the burden detection phase. Right. Now next
Where is the device implanted?
no, so this is not this is for detection. So this is outside. So it's a wristwatch type of thing.
Where?
Usually yes, it's alter chest wearable ECG. So that ECG signal is analyzed often. Now when I say it's embedded, sorry, it's an embedded device means it's a low power device, which doesn't need power supply connection. It runs on battery, and it can sort of do close to real time. Okay, you don't have to wait for days to get the report and all, and that will sort of give an indication of the atrial fibrillation burden that an individual has. Right? Now, once this burden is known, next step is what is the intervention? It could be medicine. So, as the medicine is being given, the burden could be observed how it is improving and all for a long time. And once the medicine is not working well, then the electrophysiology procedure has to be done. Right? So, for that, the next thing is what is the complexity of the procedure? Right? So, that is the next phase which is done. But I'm not sure how much we'll be able to cover. It might become heavy, but some of the basic things we'd like to cover as I'm touching this. For example, you can think that this is the tissue of the cardiac tissue pathway, and if a pulse comes at a particular point, it will go through this. This is a normal way of conduction. Now, if there is a damage in this region, this damage could be having different manifestation. One is the conduction becomes opposite, in the sense it sort of blocks the normal conduction and the conduction then happens in the reverse way. Okay, so Then what happens? This particular goes here, it stops here, and then comes back. Now, the moment it came back, it goes this way and it sort of starts rotating inside. So, if a pulse was given, it should have gone once. But if a single pulse comes here and because the tissue is damaged in a specific way, then it keeps on rotating here. So, this sort of creates a local sort of a source of electrical signals. The moment it starts rotating here, it sort of propagates to the adjacent tissues. Right? This is called rotor. Now this becomes an ectopic source. It's an artificial source which is not expected. Now this interferes with the normal way of conduction. Now because of this interference, the structural changes that happen in the systole-diastole cycles, they get disrupted. So that's a basic principle of fibrillation effect on the electrical, because of the electrical signal impairments and all, and these leads to change in blood flow efficiency and all. Now, next is how AI or algorithms or signal processing can help in this, right? Now, all these are invasive. All these are invasive means inside the heart. And they are studied using electrodes which are inserted in the heart. It's called basket electrode is there, like 64 electrode devices. These are done for research purpose and studies to develop algorithm for future purpose. The future is like this. We have 12-lead ECG, and the 12-lead ECG is supposed to tell us the location of such rotors and how many such locations are there, right? Where all it is there. So that the electrophysiology apparently knows where they need to go and sort of rectify. So that's the vision. Now, in order to do this is sort of an initial stage where you get data, how is the inside the heart is. And here, if you get the basket electrode data, you will get such signals at different points. And using the specific pattern, this will have a cyclic pattern. So, what is done? A phase analysis is done, and the phase actually has a specific characteristics, and there's a phase singularity happens. So it sort of forms a curve type of thing. Okay. And this is the work done by these fellows, which is important, and they sort of give a direction on detecting the rotor. Detecting the rotor means ectopic regions inside the heart using the electrodes. And the next is how can we detect from outside, right? So in order to do that, this is the next concept. So we saw this one as it's basically such impairments can happen because of the atrial fibrillation or maybe some other scar formation and all. These are generic arrhythmic regions, right? Reasons. And what you observe in the heart is called electrogram. So inside the heart you get electrogram signals. And from there, from inside the heart to the body surface on the torso, we see clearly ECG. So that's a body surface potential. So this is called the forward electrophysiology. It's a domain which is quite established. So one can sort of estimate how is the body surface potential from this. However, in real world, you don't have this, right? You have only body surface potential of 12 lead only. Now, this inverse estimation could then sort of get an estimate. This is called ECGI. It's like ECG imaging of the heart, right? Is an imaging, so which is equivalent to this, but it is estimated. Now the goal is how close is this estimate to this. So then, if we have a very good pipeline, then by observing the body surface, we can sort of estimate this and also estimate rotor. So that's a path. Okay. Now, before we go ahead, there are a few more things. Medtronics had a device which is 250 lead vest, like wearable on the chest. They have most of the electrodes in the front, some in the back. So while this vest is worn, inside the heart, the electrodes are inserted, 64 electrodes. So there's a mapping done between the surface and the ECG. And then they sort of established a pipeline through academic collaborations and all, where they demonstrated this from this electrode, they can actually estimate what is observed inside the heart actually. Right? So now if this pipeline is known, then we have a sort of idea that okay, we may be able to estimate, but this is 256 test, 252 plus something. Later they did with 64 lead surface electrode. So there it is stuck at 64 lead. Now what we are attempting is, so there are 2-3 words. You can note down this publication and read later. I may not be able to go in detail, but I will get the concept. The localization of those ectopic bits are usually done through some signal processing algorithms, which is using activation time and dominant frequency, because if you remember in code, you saw the circle thing, right? It goes in a loop. Now that goes in a loop very fast. So usually our heart rate is like 70-80 beats per minute. That rotor goes at 300-400 beats per minute. Okay, so then we feel palpitation. Okay, so that's a frequency of that's called very high frequency in the atrial fibrillation. So these are the signatures available, and we do processing to sort of find out where it comes from. Here, this particular work was trying to enhance the estimate using a specific combination. But what I do want to go next is, yeah, so this is one important thing. In real life, you may not have a 64 lead or 256 lead test. You will have only 12 lead ECG. So the work we are doing is from 12 lead ECG, can we estimate a dense surface potential, body surface potential, and then using the previous work, we can then localize inside the heart. So that's the goal. Now, when we started this work, we have the data set, the 64 lead surface electrode, we have it. Okay, from there we take 12 leads, which are standard ones, which maps to the standard clinically used ones, and then try to see how well we can reconstruct the remaining electrodes, because the ground truth is there. Right? So in order to do that, yeah, so these are all the images. So Nejman configuration, this is a specific configuration. They had 64 electrodes, and we are going to reconstruct these 9 electrodes, actually 9 plus 3 auxiliary electrode. Now here, here we use generative adversarial network as a standard one, but we sort of modified this, obviously this structures and all. What is fed inside is 12 lead ECG. What is found outside is 64 lead ECG. Okay, so, and this is trained using the data set and given an unknown observation. So if I have a atrial fibrillation and I go to hospital, I get 12 lead ECG. Using such algorithms, we could generate 64 lead ECG, and then using the previous algorithm, we can localize where it is actually in the heart. Right? So that's the pipeline. Now here, one small contribution was done, not much, but the philosophy is like this. These loss functions you may be aware of, may not be, but what I want to tell, this is a standard loss function of generative adversarial network, which has a generator and a discriminator. The contribution was we sort of enhance the loss function and have seen the improvement in detection, where the loss function incorporated the morphology of the ECG regions like P wave or QRS or T region. The morphology, I mean the shape, right? So whether the shapes are reconstructed well by the network. If they are not reconstructed well, then it adds to the loss function. So that's the contribution for this, and this paper tells how it is. For at this point, where are we? For atrial fibrillation, we saw okay the cause for actually the reason why the atrial fibrillation happens. Why means if it happens because of the tissue damage, what are the effects on the ECG, and can we estimate from the surface ECG where it is located and all, which will help in the electrovisualization. Now the next component of the work relates to the blood flow, the hemodynamics. Okay, so where we simulate the blood flow thing, and then of course we'll attempt to combine the electrophysiology and the hemodynamics together to achieve predictions. Okay. So I'll take a pause here before if there are any questions.
In previous slide, you showed TSG and generative means GAN and CGAN. So, what is the basis of designing and selecting these models for these particular cases?
Yeah.
Like PET GAN, CGAN.
Yeah. So the reason we chose GAN was yes, we saw that time 2-3 years back that there was some peaks to peaks GAN was there, which sort of maps a particular image to another one. So we found that was very close because we are mapping 12 lead to 65 lead. But it is a time series. It's not an image. So we had to modify the architecture. Sorry. Is it okay?
Like this.
Fine. Okay, so nothing else. So that's one thought process, the third is mapping. But it was image, so we have this time series. Now this time series, but we have multiple leads. So it sort of roughly became an image where we put 12 leads and a window size. Then it becomes an image. It's a window, it is taken like I think 300. Each 300 12 is 0 12. So then it becomes an image type of thing. And then on the output, we also get 65 rows, 65 leads, and a window signal.
And say one more, you have shown that we are used for initial stages leaky rate and later final stage sigmoid. Specific reason for choosing such activation functions in any pattern which we have noticed at different layers to choose for, or I don't know what is leaky ReLU.
Yeah.
With our ReLU. So, any specific reasons for changing activations and choosing activations or functions at different layers?
Okay, so yeah, this comes with some trial and error, but yeah, rectified left leaky ReLU there is slight difference. But yes, so sometimes it comes with trial and error, but yes, you have to get to that with an experience. It will come. There is no defined rule. So
one thing is that in case of ReLU, the network suffers with one problem called neuron dying problem. As it is taken 0 and the mod, so it suffers with that, and the model becomes sparse, and sometimes it overfits. So that's why people use now leaky ReLU, where it is not exactly 0, but it's something which is near to 0.
And slowly it comes.
Yeah.
No, but overfitting, underfitting problem means what is the reason? First 7 layer and then last. This is just a trial and error. Means you would have done it in third or fourth and then find out overfitting, underfitting, and accordingly adjust it. Not like that, right?
Yeah, so Rohan, who was finally working the first author, I'm sure he
So while selecting
did the training.
While selecting the activation function, actually there is no hard and fast. You can
That is
decide
modern
it.
first. That is
And why the last layer is taking sigmoid, because we have to classify
yes,
something.
you have to sort of truncate that, obviously. And in this case, it is sort of an estimation though. But yes, so it's a function where you sort of get different values at different input. It's a continuous function. I'm not sure whether this is being a torture sort of thing. No, right? Then it becomes very, very unfortunate. Um, because so here you hear maybe few terms which is not commonly heard, but thought it will help to sort of get an idea about. It's actually for any such surgical procedures. If you need to aid with AI, it will involve the basic understanding of the surgical procedure and the data that you get from that. What is the meaning? What are the sources? What is the normal behavior? What is abnormal? And then you need to apply it. So, yeah. So just to pause few things and talk about other things. For example, more complex procedures like deep brain stimulation, which is brain anyway is very complex. We don't understand much. For a specific disease, Parkinson's disease, an electrode is inserted inside the brain, and there is a region in the brain where the stimulation is supposed to be given. And it is seen that it improves the symptoms. Those are observed in that patients are improved. Okay, maybe tremor or some motion. But the problem is a lot of side effects. Many patients don't respond well. Neurologists' skill set varies. Neurosurgeons, sorry. Skill set varies. And there is a sort of a guideline on where to place the electrode, where to give the stimulation, but it's a lot of uncertainty. So the area of work in that, it is very similar. What they do is, in simulations, they try to understand where the stimulation has to be given, okay, which region, and what are the parameters they have to give. So there also they will follow similar path, but the complexity is much higher. The data will be different. It will involve neuronal data, electro data, but the pipeline will be very similar. Okay, so coming back to this cardiovascular hemodynamic model. So if you remember, we saw these four chambers, ventricle, two ventricles, and two atria. It is shown schematically like this. And there is a pulmonary circulation, there is a systemic circulation to the body. And yeah, we don't have to go in detail, but two important things to note that there is a volume, then there is a pressure, there's compliance, and the Q, the flow. So these are some of the things which is driven by physics equation. We'll see next slide. And there are some valves available, so which sort of controls the flow of between the ventricles and outside it. So they are important. Now, this is sort of, and there are two things which will not cover, but it is a baroreflex. It's auto-regulation. So when we run, jog, when we are stressed, this is a brain controlled. Not always brain. Sometimes in the spinal cord circuit it is there. So this reflex controls the cardiac properties, to change the heart rate, to change the efficiency and all. So that's another complexity. But here, the way we follow is this pressure derivative with the pressure of the left ventricle is relates with the compliance function. Okay, so using a pressure volume equation, this is a standard one. And this is a contractility function. Now these you can look into one paper, it is there. But what is important is using these equations, initially we create a simulation platform which sort of generates a blood flow signature in the ventricle and atrium over the systolic and diastolic cycle, which is sort of generic for a healthy individual. Now in disease condition, that gets changed, right? So yeah, so this is one scenario where a valvular disease condition its specific thing is mitral stenosis. Stenosis is basically the mitral valve orifice got reduced, and hence the flow is obstructed. Right. So in simulation, what we do, we have that equation where we, there is a factor which is called resistance, RMI. Yeah, so in this one, this mitral valve, any valve, it is 0 or 1, it is closed or open. This becomes a function which is a variable, and that gets sort of programmed, and then we sort of achieve the stenosis. Now, what is important to know is this left ventricle volume and left ventricle pressure. This characteristic is a signature of the blood flow. And in case of no mitral stenosis, is normal, the green. This is the characteristic. Okay, it has the same systolic and systolic time points and all. Now, in case of stenosis, depending on the severity, this gets changed. Now, how this is observed? This is observed in echo. Okay, so that is known, and we will get these signatures. The thing is, so now this volume and pressure is called PV loop. Now, in case of arrhythmia or some ventricular diseases, also this loop might get changed, and in static condition in hospitals, this is observed. However, in daily living condition, we don't have echo information. Right? We have only ECG. If it is chest variable, we get continuous ECG. Now, using this simulation tool, using the ECG only, and the signatures from the ECG, the RR intervals and the T wave and this wave, we drive the hemodynamics. That's in the next phase. So, using this ECG, we actually drive within the simulation. We run the hemodynamics to get an estimate of the echo in the outside the clinic. Right. So, here this contractility estimation is done. Okay, so contractility of the heart means is basically the amount of force the tissue is giving, able to generate for pushing the blood, right? So we sort of connect this ECG to the hemodynamics, and it could do predictions. So, for example, if an individual has undergone some procedure or some surgery, and we observe the echo data post surgery in static condition, then on the daily living condition, given this simulation platform and the wearable data, it could generate the cardiovascular parameters like blood flow and all. So, yeah, these are some of the results. Now, these terms relates to the volume, pressure, and the efficiency of the heart. Okay, the experimental value means these are actually observed by medical fraternity in the healthy condition, and in the simulations we get similar results. We have done similar things for valvular disease and scenarios where the ischemic conditions in the coronary artery, many of you know, coronary artery sort of supplies oxygen to the heart. Now, if the coronary artery is blocked or partially blocked, the oxygen supply to the heart muscles get sort of impaired, which leads to the damage in the heart muscles itself, and that leads to reduction in efficiency, and then you need sometimes to do those angioplasty or bypass and all to rectify that, right? But before you go there, the arrhythmia, the ischemic conditions or degeneration has started, and doctors do multiple tests. They do ECG, echo, TMT, and the gold standard is the angiogram, where they know how much is the blockage. Now, after angiogram, if they find that the procedure has to be done, they will do or they will not. But if we have that information where the procedure is not yet done, this particular environment can actually do simulations in the daily living conditions. So, for example, what happens when we are in resting condition, our heart is sort of normally beating at 70, 80 beats per minute, but we are stressed or doing some exercise, then the heartbeat goes to 120, 130, and that time that ischemic condition gets more adverse, okay? And hence the heart attack or sudden cardiac death happens. Now, such things could be sort of simulated in this condition, okay, in this type of simulation platform. Okay, this individual, if he does this, what happens in such scenario? Because it's called stress-induced ischemia. So this type of digital thing can actually assist in sort of guiding an individual's daily living condition who are risk prone, right? And also help the cardiologist or electrophysiologist do planning of the procedure. So this is what I told. So it's basically forecasting based on ambulatory data. An individual wearing this PPG sensor, PPG is photoplethysmograph sensor, and IMU sort of gives an indication of the intensity of the activity and the movement. And then it could also give the heart rate or the breathing rate and get an idea about the cardiac fatigue. So given an intensity of activity, how much is the heart rate, how it recovers and all. The digital twin, which encompasses electrophysiology, biomechanics and hemodynamics, can do sort of predictions on what is the expected one. And the difference of these two can sort of generate alerts and risks. Right? So that way, the work we focus on combining this wearable information with the simulation, which is a digital twin, to sort of assist an individual's journey from both pre and post surgery. So this is ischemic condition I have sort of covered. Yeah, I'm not going to. So this one I'm going to touch a bit. This relates to the structure of the heart. So we covered electrophysiology, we covered hemodynamics, blood flow. And the third one is related to the structure of the heart, where the MRI or the CT sort of gives structural information. And these are some of the sample slices which usually the cardiologist will see and decide on multiple things. One is where are the scar formation is, right? Because usually for scar information this is done. For cardiac MRI is not so common. It's done in special cases. But for pediatric condition where there is a congenital heart disease, there is a structural defect, they need to be rectified. In such scenario, this is done. Now the work that we have done is on adult data set. We haven't done on pediatric yet, but we'll go there in future. So the contribution from the image processing is like segmentation. Segmentation means this is left ventricle, right ventricle, atrium, and also from the MRI images, this image processing algorithm segments automatically and it extracts the dimension information. Now you see this is a static thing, right? But heart is beating, so when the MRI is taking, this is called cine MRI mode, the beating heart is imaged. So for diastole, endpoint diastole or endpoint systole or continuously, this is segmented and the measurements are done. Apart from that, the landmark detection is important. I will just go this specific thing. For example, this point you see, this red dot and this red dot. This is important because these are the key points for the right ventricle. Okay, to derive the measurements. Now, if you need to automate the process, this fiducial points need to be known. So it's not only segmentation, but it also tries to find important points which are critical to derive dimension information. So same way here, these 2 points. Right? And this is the junction where the bulb is. This is atrium, this is ventricle. And so this reference is I think I'll address this later, but if you search with name, yeah, I'll tell you. Maybe I'll update the paper name here, which sort of gives the prediction. And it finally compares the performance of the proposed algorithm with many other. And you see, each of these people have used multiple networks. They have used density net. Now, this is a domain where it's been difficult. Many of us don't consciously choose networks. We see what is the latest network and try to apply. It's not much of a scientific thing yet. But what is important is this augmentation, data augmentation. So the MRI data is augmented with synthetically generated data. And this augmentation is usually done through rotation or blurring, right? So image processing, and it is seen to improve the performance. Yeah, so basically it has this input MRI images, and then we do pre-processing, and then augmentation, and then segmentation. After that, okay, so this is the work which detected cardiac anomaly. So from the MRI image, we can also detect some cardiac diseases, okay, automatically. And these diseases are like dilated cardiomyopathy. These are medical terms, but so for example, here 4 diseases were there, and a normal data was there. So these MRI, these are open data sets, and these are publication you can refer to. So here the network was trained after feature extraction. The classifier was trained with these 5 classes, and then given an unknown data, it was able to detect whether it's normal or one of those diseases. Right? Now, so this is related to segmentation, landmark detection, and disease detection wherever it is required, right? And the performance data are provided. It sort of gives more detail on how is the ground for them. Yeah, I think I'll just pause here and just tell. So where we'll be heading next is these MRI images are slices, slices to cover the full heart. Right? Now the next thing which is important is to create a 3D mesh from this MRI data. So when we have the mesh structure, mesh means sort of a surface which sort of has those vertices and faces, forms a mesh. And the moment we have that, and we have the 3D flow, blood flow. We haven't done the 3D blood flow yet. What we saw was 0D. Then the fluid structure interaction can be studied. So that we are developing now. We haven't gone there, but the next phase of this is mesh generation and fluid structure interaction. And once we have that, then in case of structural changes in the heart, what happens in the fluid flow post structural changes? So in the mesh, we can actually change the structure and then do simulations to study the fluid structure interaction, the change in pressure volume. So that's the next thing that people are doing research on, and we have started that and yet to go along. So that's a connection that you have one after another. And this I'll just cover briefly. Why it is important is there are 13% of child patients have the mortality, which is actually not good. And every 8 of 10 children is having this congenital heart disease out of 1,000 births. Now, so it is very important to sort of assist in surgery. And the pediatric surgeon, they admitted this, and we have discussed with Amrita Hospital, Dr. Mahesh L, and we have discussed with Fortis Hospital, Delhi, Dr. Iyer. Dr. Iyer has been in practice for 30 years. And he told, yes, many a times there are complex procedures where they have alternatives to choose from. Okay, so they could. Um, so among those alternatives, what is best? Now, depending on the experience they do, but there is no simulations done to sort of quantify what is the comparison among alternatives. So such simulations will in future hopefully going to help us. Yes. So that's the flow we have. So for example, the patient will have MRI and then we do segmentation. We can create this mesh generation on a beating heart and educate. So this one is showing some output of the blood flow information at normal or certain disease condition like mitral stenosis, regurgitation or something. And those are various parameters we just discussed, like left ventricle, pressure or volume. So x-axis is time, y-axis is say pressure. It sort of gives different parameters, mitral valve flow and all in normal condition. And this gives the pressure volume loop. Horizontal is volume, vertical pressure of the left ventricle. If you have a say mitral stenosis which is severe, then how it will be? It will be sort of plotted overlaid on the normal. Normal is shown in orange. Blue is in the disease condition. So this change is sort of getting quantified how it is, and these various parameters, and it will also have this various exercise levels on the right side. One can choose the PMI and the exercise level how it will change. So this simulation platform can actually generate this information, given that the knowledge it has learned from. So this one, sometimes I told during the talk, but this is a summary of the post-operative scenario, okay, which uses the exercise model. So a patient which is having this personalized data, the metadata, medicine information, wearable information, and there is a generalized cardiac model. When I say cardiac model, we saw this electrophysiology, hemodynamics information, and that is generalized, and that model is personalized using this individual information. And we have this exercise model, which is also taking the wearable data and all to personalize, and then it can do sort of simulate cardiac condition and predict critical events, generate reports, and such things. So this one we are starting a study with Fortis Hospital to sort of recruit patients who are undergone surgery, and then taking the clinical data and all, do simulations and also provide additional information to the cardiologist and see whether that helps cardiologists to sort of plan post-surgery treatment, right, and recovery. So that's something which will be sort of longitudinal study, but it's important to demonstrate the impact. And covering the cardiac model, this is the in silico computation model. On the bottom you see multiple modalities of the data, the imaging data, the echo, wearable data, animal studies information, and patient trial data. So all these data are actually used to develop models, structural information, hemodynamics, electrophysiology, and also we develop explainable AI models to explain rhythmic analysis, conditions. So that sort of encompasses the digital twin with multiple applications about source localization of disease condition or surgical planning, cardiac risk generation, rehab. In future, we aim to integrate the genomics information, which is more precise in nature. So it sort of, we are close to the end of the talk. I skipped some detail in between, but when I share the slides with Refine, you will get additional information on some ischemic condition, how the AI is used, how the models are used. I think that's one of the important things which we missed. So here some of the challenges on ethical consideration. So here you see this technical implementation and challenges. So integration of the existing system. The existing system in the sense the existing practice they have that today, right? So pre-surgery planning, during surgery, post-surgery. There is a practice that happens today now. How do we integrate some of these components into this practice, right? Need for robust training data. So much of data is required to actually make the machine learning algorithms more robust. And obviously challenge in deployment because with hospital collaborations only we can demonstrate impact, and then it's a long process where we will get into the technical community. Ethical considerations and legal considerations are very important. Like accountability for errors. If AI is doing mistake, who is accountable for that? Hence, it needs a transparency in decision making and trust. So they come through explanation. Right? So when a cardiologist says something to the peer one, they tell, okay, this is the reason I'm saying. So the machine also should say in the same language. Then only they will have the understanding, okay, they trust this, otherwise they will not. And finally, it should ensure patient safety and data privacy. These are the future trends that you can look for. It's like predicted advancements in AI technology. It's more of personalized digital twin robotic system improving patient outcomes. And impacts are obviously improved success rate, reduced complications and recovery experience, and equal access to surgery, education and training professionals. This we haven't covered much, but training for professionals and personalized learning experience is important because new professionals who are coming in this surgical procedure, they are novice, right? So how can they become close to experts early is very important, and there the AI is going to help through simulations and through interaction, right? Which, yeah. And so to conclude, we see that AI assistance the surgery in all the phases. So pre-surgery for planning patient selection. Patient selection is very important. How to do, not to do. Who are the responders who would not be responding. So, and if we can predict early, that will be great. During surgery, robotics and multimodal fusion. Multimodal fusion and multimodal data fusion during surgery can assist the surgeon. And post-surgery, the personality have. It's a multidisciplinary approach because the devices, medical devices are getting enhanced. They are coming up with new capabilities. So which the AI need to be incorporating the pharmacology is another area. The medicine effects on the surgery is very important because they are very complicated. Outcomes depend on both together. It's not separate. And data analysis. And finally, the patient-centric approach is important. It should finally benefit the patients with improved outcome. And it should reduce recurrence and mortality. So readmission recurrence should reduce. Right? So that's the goal we have, and let's see how it is. Okay, so that's thank you very much for listening to me. Any questions, any discussion?
We are going to develop computational cardiac hemodynamic model using MRI. On the other hand, it would also provide good hemodynamic profile of heart. So why you prefer MRI signal instead of echo-Doppler?
Yeah. So the initial phase before the MRI cardiac imaging, what I told was with echo only, echo and ECG data. We can develop hemodynamic model. The MRI is used to sort of create the structure, and if we need to study the structure fluid interaction, then we need it. Otherwise, we don't. So, for very few selected patients, MRI will be used, like congenital heart disease, which is rare. For most of it, it will be echo and ECG only. Yeah.
So actually, I have to clear few of my doubts. So in your second paper, you are using ECG signal to feed the CNN.
Okay.
Right, sir? So now the question is, this is a signal, not an image, and CNN is good for the images. So why you are choosing CNN to process the signal?
Yeah. So okay. So if we go back, I'm not sure. So in electronics, when we studied filters, low pass, high pass, band. They used to do convolution, right? So and they filter out frequency bands. Now the image CNN came from there. Okay, so it's a convolution they do into.
That means you are not directly feeding the PQRS signal into the CNN.
Yeah. So we have two versions. So the PQRST can be stacked for multiple leads. If you have 12 leads, you can stack 12 rows and take a window. The signal becomes an image. Right? So you can do convolution in time and adjacent leads. So then it becomes image like. But if you have one lead signal, one lead ECG signal, then you do a convolution only on the time series.
Into the CNN.
So CNN you can run in 1D mode also.
Yes, but the result is not means.
Yeah, so it depends on how you apply it. So CNN is equivalent to a filter. Okay, so it's an interfilter with a convolution. It learns the weight of the filter. So sometimes it depends on the scenario, it will work.
Yes.
Always it will not work. Other thing what we do is we create a spectrogram. Time series signal with time frequency spectrogram. Then we use the spectrogram to feed to CNN. So
that is okay.
Yeah, we do that too. But in this paper, what was done, I have to check. But yeah, these are multiple alternatives.
Yeah.
Depending on how it goes.
And the other question is, sir, in your first paper, you are using a RGB image into the CNN. Then what is the purpose of GT?
Ground truth.
Yes.
Okay. See, RGB are the three channels that is captured from camera. Ground truth is single, right? Because it's the absolute.
That means you are feeding two signals into the CNN.
Yeah. So CNN will take the input image, the video. Output it will do the prediction or whatever. And then it will compare the error against ground truth, and then it will update the weights.
That point is not clear. Against ground truth means what? How the ground truth?
Okay, so in the data set, the RGB data and the ground truth are provided.
Yes. Okay.
The ground truth for a specific thing, right?
Okay.
Now the RGB data passed through the algorithm should generate a segmentation.
And the prediction is compared with the ground truth.
Yeah, which should match with the ground truth. During learning process, the ground truth is used to train.
That is for the training purpose only.
Training purpose. For testing purpose, you need to use the ground truth to test how well the prediction is.
Yes.
So both are done using text.
Thank you, sir.
Thank you, sir. Any question? If there are no more questions, let me conclude this session by thanking the speaker for such an exciting and lucid lecture. I am sure all of you have enjoyed it and learned important lessons on emerging techniques based on artificial intelligence that is already in use even for highly delicate and complex medical surgery. Please join me in thanking the speaker once again for this wonderful lecture. Thank you, sir.
Thank you very much.
Sir, Dhruva sir, please again give the certificate.
I'd like to request the moderator and co-coordinator to join me to please join you. Co-coordinator. Moderator.
তাহলে কি হয় আমার বডির মেটাবলিক রেট আস্তে আস্তে কমে যায়, সেজন্য আমার প্রেসার কিন্তু ফলো করতে পারে। বা যদি আমরা ডিহাইড্রেশনে তাহলেও কিন্তু প্রেসার অনেক সময় ফলো করে। বা যদি কোনো আমার টেনশন বা এই সমস্ত ক্ষেত্রে কিন্তু আমার প্রেসার অনেক সময় লো ডাউন হয়ে যায়। তো সেখানে মেডিকেলি আমাদের বলা হয়েছে যে কারোর যদি ব্লাড প্রেসার লেস দ্যান ইকুয়াল টু 90/60, অর্থাৎ আমার যেটা সিস্টোল সেটা যদি আমার 90 এবং ড্যাশ টু সেটা হচ্ছে আমার 60, আমার যদি ব্লাড প্রেসার লেস দ্যান ইকুয়াল টু 90/60 হয় তাহলে সেটা আমরা বলবো হাইপোটেনশন। ওকে, এবার একটা হয় যেটা আমরা বললাম যে বেড়ে যাওয়াটাকে আমরা কি বলবো না হাইপারটেনশন। সেম যেভাবে আমার ঘুম ছিল যখন 115 বা 118 যখন আসলো, তেমনি আমার বেড়ে যাওয়াটাও 121, 120 আমার নরমাল, আমি বললাম 121 বা 125, 130, সবাই হচ্ছে আমরা 120 উপরে। তো তাহলে তাকে কি আমরা হাইপারটেনশন বলবো না? তাকেও কিন্তু আমরা হাইপারটেনশন বলবো না। এখানে আমার হাইপারটেনশন কিছু স্টেজেস একদম বয়সের সাথে সাথে এটা রেগুলেট করে এবং এটা এবার যেটা
আমার বিপি শুট করবে তারপরে কতক্ষণ টাইম লাগবে আমাকে নরমাল আবার যখন আমি সকালে ভুল করে ওই বিপি মেডিসিনটা নিই, ওই ট্রেনে আস্তে আস্তে একটা শুট তারপর এখন তো ঠিক লাগছে।
হ্যাঁ, তখন
আমার ফল্ট আমি এখন ঠিক আছে। ওই আসার সময় লাগছিল।
হ্যাঁ, কারণ স্যার আমার আরো সময় লাগছিল এই জন্য যে আপনি কিন্তু তখন হাঁটাহাঁটি করেছে বা বাস চেঞ্জ করেছে একদম না, সেই জন্য আমাদের আছে তখন
কায়দাটা দৌড়ে উঠে
হ্যাঁ সেই স্টেশন জন্য আমরা ডিবেটে কিন্তু তখন যে রেঞ্জেসটা কিন্তু চেঞ্জ হয়েছে। এখন আপনি নর্মাল অবস্থায় আছেন, একটা নর্মাল ওয়েজে আছেন
না, আরেকটা কারণ সকালে মেডিসিনটা খাই
সেটা এমনি খুব ছোট, আপনি যদি মেডিসিন খেতেন আপনি ছোটাছুটি করে করতে পারবেন
বোতল না হয় না।
হ্যাঁ, কিন্তু আপনি যেহেতু মেডিসিনটা নেননি সেই জন্য আপনি একটা স্ট্রেসের মধ্যে দিয়ে এসেছেন বা একটা দৌড়াদৌড়ি করেছেন, হাঁটাহাঁটি করেছেন, সেই জন্য আপনি ডিবেটটা একটা অ্যাংজাইটির জন্য বেরিয়ে গেছে। কিন্তু এখন আপনি যেহেতু একটা নর্মাল স্টেটে আছেন সেই জন্য আপনি ডিবেটটা
নর্মাল বিপি নর্মাল আছে কি করব, যেমন আপনি এখন মাপলে বুঝতে পারবেন বিপি কত আছে।
হ্যাঁ,
তো আমি কি করে ফিল করব, আমার সিম্পটম কি করে দেয় বিপি স্ট্রেস সিম্পটম
না,
বিপি সকালে চলে যাচ্ছে ওই যে
হ্যাঁ বিপি নর্মাল আছে আপনি বুঝবো কি করে? ওটা আমাকে নর্মাল ভ্যালু জানতে গেলে আমাকে চেক করে ছাড়া অস্পষ্ট হয়ে যাবে। কিন্তু যদি আপনাকে বলছি সাইড এফেক্ট হবে, আমি কোশ্চেন আমাকে অ্যানসার দিই না,
তারপর কিছু তোমাদের নর্মাল ফিল করব
আমি বলে দিচ্ছি স্যার, আপনাকে
সত্যি
আমি
নর্মাল
বলে দিচ্ছি আপনার বিপিটা কত অ্যাকচুয়াল ভ্যালু আছে সেটা আমরা না মাপে বুঝতে পারবো। এবার আপনি যেটা বলতেছি আমার বিপি বেশি আছে না বা কমে গেছে
কিনা
না বলছি এটা আমি বুঝবো কি করে? বুঝবো যদি আপনার বিপি খুব বেশি বেড়ে যায় আপনি চোখে দেখবেন বা মাথাটা ঘুরছে, এবং স্যার যে মাথাটা বললেন এটা হচ্ছে আপনার পালস রেট কিন্তু আস্তে আস্তে বাড়বে। কেন পালস রেট বাড়বে? কারণ আমরা বিপি বাড়ছে মানে হাতের মধ্যে আমার কন্ট্রাকশন রিলেশন বাড়ছে, এটা যদি বাড়ে আর বাড়ে আমার যে আর্টারিজগুলো আছে তার ফ্লো বাড়বে, ফ্লো বাড়লে আমি
বয়সের সময় তো এগুলো চেক হয়
সেটা আলাদা, সেটা 60 সেটা আলাদা ফিজিওলজিক্যাল ফ্যাক্টর পালস বাড়লে বিপি বাড়বে না বিপি বাড়লে
বিপি বাড়লে
বিপি বাড়লে কারণ বাড়লে
সেদিন আমার পাস দেখাও তখন কিন্তু আমার মাথাটা একটু ডিজিনেস ফিল হচ্ছে আর হচ্ছে তখন আমার বিপিটা মাপিয়েছি সেটা লো আছে এবং যেটা 115 বাই 80
তাহলে ওটা কিছু আপনার কিছু সেকেন্ডের জন্য কিছু আমি স্ট্রেসের মধ্যে দিয়ে 70 আচ্ছা কিছু করে জন্য আপনি কি করবেন জানেন
অনেক সময় বডি ওয়েট আপনি নিচের ভ্যালুটা মানে নিচের মতো 80 থেকে 100 বা 60 ওইটা কেন বেশি মানে গুরুত্ব
স্যার 120 বাই আছে তো 120 হচ্ছে কোন স্পিডে আপনার হাঁটতে যাচ্ছে 80 হচ্ছে কোন স্পিডে হাঁটতে পর্যন্ত ওইটা বাড়লে ক্ষতি হাঁটে আসুন ডেসিবেলে আসুন
সেটাই বলছি
আর ওটাকে ওইখানে এসি নোটে কাজ হয়ে যাবে ওটাকে সাপ্রেস করে এসা থেকে আটকা দিয়ে অল্প স্পিডে ছাড়ে যাতে অর্গানগুলো যেন সাপ্লাই করতে পারে মানে 120 স্পিডে যদি ছাড়তো সেটা অর্গান
100 স্পিড ছাড়লে অর্গান কেটে যেত
এটা আমার স্যার বলে এই যে আপনি যে বলছেন এটা দেওয়ার এই যে এখন চলো ট্যাপিং আপনার চোখে দেখলে দাঁড়িয়ে চাপসা হয়ে যাওয়া বা আমার মাথা ঝিমুড়ি টাইপের আসবে এবং সবচেয়ে যেটা হচ্ছে এক্সেসিভ সোয়েটিং আমি এগুলো হচ্ছে আর বিপি যে বেড়ে যাচ্ছে সেগুলো আলাদা যদি এক্সেসিভ আপনি নেমে যান তাহলে সেটা যদি আমরা ওয়ার্ডে বা এগুলো যদি আমরা ট্রিটমেন্টের মধ্যে দিয়ে না যাই তাহলে কিন্তু বিপি আবার কারণ ঘামের সঙ্গে আমার সোডিয়াম পটাশিয়াম ইকুইলাইট ইমব্যালেন্স হয়ে যায় তখন আমার কার্ডিয়াক পারফিউশন নরমালি আর
সোডিয়াম পটাশিয়ামের মানে ব্যাপারটা কি কারণে এটা অনেক বয়স্ক লোকেরা দেখেছি
পটাশিয়ামের ব্যাপারটা হচ্ছে এগুলোকে আমাদের ইলেকট্রোলাইটস বেসিক থিওরি আছে আমাদের
আমরা তো নুন জল খাই আমি
সোডিয়াম পটাশিয়ামের ব্যালেন্সটা
সেখানে অ্যাডিনালে না অ্যালডোস্টেরন অ্যালডোস্টেরন ইজ রেসপন্সিবল ফর সোডিয়াম পটাশিয়াম ব্যালেন্স এইটা মানে এইটা এক্সেসিভ মানে বা সিচুয়েশন চেক করতে পারবে না এবং আমরা আপনার বডিতে সোডিয়াম পটাশিয়ামের আর্নিং ব্যালেন্স না যখন কমে যাবে তখন অ্যালডোস্টেরন সিক্রেট করে অ্যালডোস্টেরন একটু খারাপ হবে রেসপন্স করে তাকে রেসপন্স করে সে অ্যাক্টিভিটাস অ্যাক্টিভ অনেকে তো নুন জল খায় চিনি খায় কারণ সোডিয়াম পটাশিয়াম কমে গেছে এগুলো
তখন কি হয় বাইরে বেরিয়ে আসে সেই জন্য আমরা সোডিয়াম পটাশিয়াম ফলো করি এবার সেটা আলাদা আলাদা জিনিস সোডিয়াম পটাশিয়াম যদি ফলো হয় সেটা আপনার প্রপার মেডিসিন আছে সেগুলো আলাদা আলাদা জিনিস তো আজকে আমাদের যেটা বেসিক ছিল সেটা হচ্ছে তার প্রেশারটা তো এবার আজকে আমরা ম্যানুয়ালি যে ব্লাড প্রেশার চেকিং বা ম্যানুয়ালি যে স্পিডো মেশিনের মাধ্যমে প্রেশার চেকিং করা হয় সেটা জাস্ট আমি একটা বেসিক তো
আমার কি না
স্যার আমি আমাদের গ্রাউন্ড ট্রুথ হবে
সকালে আইসক্রিম ভিডিও করতে ভুলে গেছি ব্যাগে ভুলে গেছি আমাদের
ম্যানুয়াল রিভিউ চেকিং এর জন্য কি দরকার হয় তার ফার্স্ট হচ্ছে আমাদের একটা বিপি এটাকে আমরা স্পিউমোমিটার বলি মেডিকেলি। দেন হচ্ছে আমাদের স্টেথোস্কোপ। এই বিপি কাফ স্পিউমোমিটারে দেখবেন বিভিন্ন পার্টস থাকে। এটা হচ্ছে আমার কাফ, ওকে। এটা হচ্ছে একটা ডায়াল, যেখানে দেখবেন বিভিন্ন আমার যে মার্কিং করা থাকে 20, 40, 60 এভাবে মার্কিং আছে। এবার এই যে 20 সবাই দেখলে সুবিধা হতো, 20 আছে। হ্যাঁ, এখানে হচ্ছে ইচ যে লাইন, সেটা এক একটা লাইন হচ্ছে 2 mm অফ ইচ, ওকে। তো 20 না 20 আছে। দেন আমার 1, 2, 3, 4, 5 এটা 5 এ আবার এটা হচ্ছে আমার 30। তারপর আবার 4টি পর আবার একটা বড় সেটা হচ্ছে 40। এভাবে প্রতিটা ছোট ঘর মানে হচ্ছে 2, ওকে। 2 mm অফ ইচ, 20, 40, 60, 80 ভাবে মার্কিং আছে আমার। তো আর এটা হচ্ছে আমার বাল্ব, এখানে এটা হচ্ছে একটা বাল্ব আছে। এটা বাল্বটাকে আমরা এভাবে অ্যান্টি ক্লকওয়াইজ ঘুরিয়ে দিতে পারি, দেন ক্লকওয়াইজ ভাবে আমরা এটাকে লাইট করে দিই। তো ফার্স্ট আমাকে
আমি বলে দিই, এটা অ্যাকচুয়ালি চুজ করা হচ্ছে এই কারণে বাড়িতে তো আমরা ডিজিটাল ইউজ করি, আর ডিজিটাল গুলো মানে অপটিক্যাল আছে, ওগুলোর মধ্যে এটা প্লাস মাইনাস দেখবে জানি না সবই করে অ্যানিমেশনে প্লাস মাইনাস আছে।
তো রেগুলার চেক করা যায়।
তো ফার্স্ট হচ্ছে যে আমাদের এই যে কাপটা র‍্যাপ করব কোথায় না, দেখুন এই যে আমার হাতটা যে বেন্ড করছে এই জায়গা থেকে 2.5 ইঞ্চ, ওকে। তাহলে ওটা হচ্ছে যে মানে নরমাল আমরা যেভাবে র‍্যাপ করি সেখানে বেন্ড এটাকে টাইট না, ঠিক আছে। দেন আমার হাত থাকবে কোথায় না, হার্ট লেভেল, রিল্যাক্স এন্ড হার্ট লেভেল। কেন হার্ট লেভেল? কারণ আমি যদি হাতটা ঠিক নিচে না পাই তাহলে কি হবে, আমার গ্র্যাভিটেশনাল ফোর্সের জন্য আমার আর্টারিজের মধ্যে ব্লাড ফ্লো বেড়ে যাবে, তাহলে প্রেসার আমার আবার বেশি আসবে। কারণ যদি উপরে রাখি তাহলে আমার প্রেসার কম হবে, অর্থাৎ আমার ন্যাচারাল যে প্রেসার সেটা কিন্তু শো হবে। সেই জন্য আমাদের হাতটা রেস্টিং হয়ে যাবে এবং অ্যাজ ওয়েল অ্যাজ হার্ট লেভেল। স্টেথো দেন হচ্ছে এটা স্টেথো প্লেসমেন্ট। আমরা যেটা ডিজিটালি চেক করি, ডিজিটালি চেকিং এর ক্ষেত্রে কিন্তু কোনো স্টেথো আমরা প্লেস করি না। তো এখানেই হচ্ছে আমার স্টেথো প্লেসমেন্ট কোথায় করা হয় না, আমরা প্রেসার চেক করছি কি করলাম না আর্টারি, ওকে। তো আর্টারি এখানে আমাদের ব্র্যাকিয়াল আর্টারি কোথায়, এদিকে মানে আমাদের অ্যানাটমির মধ্যে এখানে একটা ইমাজিনারি অ্যান্টি পিউবিটাল ফোসা, একটা ইমাজিনারি প্লেন আছে আমার অ্যান্টি পিউবিটাল ফোসা। দেন এই সাইডে আমার যেটাকে না ব্ল্যাক, আপনারা যে যার হাতের এই জায়গাটা একটু দেখুন, বুঝতে পারবেন, পালসটা ফিল করতে পারবেন সবাই পারবেন। তো সেই জায়গাটি প্রপারলি আমাকে স্টেথোটাকে প্লেস করতে হবে। এন্ড দেন প্লেসিং এর পর কি না, অনেকে কি করে না এইভাবে করে, বা সাপোজ ধরুন আমি এইভাবে করছি, তাহলে কি হচ্ছে না দেখুন এখানে আমার একটা গ্যাপ হয়ে যাচ্ছে। তো প্রপারলি আমি কিন্তু সাউন্ড তখন নাও পেতে পারি। সেই জন্য এটাকে প্রপারলি ফিট করার জন্য আমি দু আঙুলে প্রেস করলে কি হবে, প্রপারলি আমার এই রিজিয়নটার মধ্যে আমার স্টেথোর যে ডায়াফ্রামটা আছে সেই ডায়াফ্রামটা কিন্তু প্রপারলি এখানে প্লেস করছে। হ্যাঁ আমি অবশ্যই আমি আপনাকে শুনি, আপনি নিজে বুঝতে পারবেন। আমরা কি প্রথমে কোনো আওয়াজ পাবো? ফার্স্ট কিন্তু আমরা কোনো সাউন্ড পাবো না। কেন পাবো না? কারণ আমার আর্টারিজের মধ্যে থেকে কিন্তু ব্লাড অলরেডি ফ্লো করছে। তো আমরা তখন আওয়াজ পাবো না। আমরা এই যে ডায়ালটা যখন আমরা পাম্প করবো, পাম্প করে কি করবো, আমরা মোটামুটি যেটা মেডিকেলি 180 to 200 মিনিমাম এই যে পর্যন্ত আমরা ডায়ালে কাটাটাকে দিয়ে দেবো। দেন কি করবো না, আমরা ইচ সেকেন্ডে 2 mm of Hg করে আমরা প্রেসার রিলিজ করতে থাকি। তো রিলিজ করতে 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 একটা যে পয়েন্টে আমরা ফার্স্ট একটা মানে জাস্ট আমি কানে শুনি ডিপ, এইভাবে একটা সাউন্ড আছে। এই সাউন্ডে যখনই আমরা পাবো সেটা হচ্ছে আমার ফার্স্ট ভ্যালু, অর্থাৎ আমার সিস্টোলিক রেট। দেন কি হয় হাইটার, একদম ফার্স্ট যে আমরা কানে যে একটা বিট পাবো সেটা হচ্ছে আমার সিস্টোলিক। দেন কি হবে না আপনারা দেখবেন যে আস্তে আস্তে এই যে ভ্যালুটা আস্তে আস্তে প্রথমে সার্ভ, প্রথমে সার্ভ হবে, মানে কানে যেন বাজছে এরকম একটা হবে। দেন আস্তে 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 প্রেশারটা মানে আওয়াজটা আস্তে আস্তে বাড়বে, আস্তে আস্তে আমি আরো বেশি ফিল করবো, করতে 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 একটা যে পয়েন্টে প্রেশারটা কাট অফ হয়ে যাবে, একদম পুরো বন্ধ হয়ে যাবে, সেই জায়গায় আমি কি পাচ্ছি সেটা হচ্ছে আমার ড্যাশ। ফার্স্ট যে কোন সাউন্ড আমরা পাবো সেটা হচ্ছে আমার সিস্টোল, এবং লাস্ট যে পয়েন্টে আমি সাউন্ড পুরো বন্ধ সেটা হয়ে যাচ্ছে আমার ড্যাশ। এই যে আমার সিরিজ অফ সাউন্ড আছে এটাকে বলা হয় কোড অফ সাউন্ড। আর আবার কিছু 5টা ফেজ থাকে, 5টা ফেজে এটা উনি আবিষ্কার করেছিলেন, তো ওই জন্য ওনার নাম হচ্ছে এটা। তো ফার্স্ট এটা হচ্ছে আমার এদিকে কোয়ালে হচ্ছে আমার জুস, এভাবে আমি ভালভটাকে ক্লোজ করে দিই। দেন এয়ার দিচ্ছি, এটা আমার ফুলছে মানে নিয়ে গেল। দেন আমি কি করবো না আস্তে আস্তে এটাকে ছাড়ছি, অ্যান্টি ক্লক ওয়াইজ আমি আস্তে আস্তে ছাড়ছি। এটা আপনি কানে আপনি কানে দিন। হ্যাঁ আওয়াজ পাচ্ছে? কষ্ট শুনুন। একটা সাউন্ড যেন দূর থেকে বেশি আসছে, আমাকে উঠে নিয়ে হচ্ছে না, ওখান থেকে সাউন্ড আস্তে আস্তে বাড়ছে। এই হলো সাউন্ডটা। এবার দেখুন